Okay, so back to speaking on reference ranges, what's kind of normal when it comes to females and their estradiol, progesterone, and testosterone, all right? So estradiol, let's start with that. Estradiol, as we know, cyclically ebbs and flows. In your follicular phase, when you're bleeding in days 1 through 5, let's assume you're normal, right? And you have a 5-day period. Days 1 through 5, your estradiol is slowly building up. It peaks around your day 13 of your cycle, assuming you have a normal 28-day cycle. It falls sharply after ovulation because day 13 reflects the egg being released from your ovary into the fallopian tube for fertility purposes, if possible. And then after it has peaked, the egg has been released, your estradiol falls, and then it slowly builds up again, but not to the peak that it did at day 13. It kind of mimics now your progesterone curve. We'll talk about that in a minute. And then it ebbs back down, and when it finally falls off, that signals to your uterus to shed its lining, and that's when you start menstruation once again. So I'm a believer that when we check your estradiol, I need to know where in your cycle you are if we can track that best for you. So I tend to like to capture estradiol in a premenstrual female, and not every provider does this because it can be hard to know the accuracy if that was really ovulation day or not. But I like to check your estradiol, its peak window, and it should be somewhere between 150 to 300. I had to write down reference ranges just to make sure I was cool. PG per ml. Okay, so picograms per milliliter. And I like to look for that and see, are we achieving kind of that mark? Are we way above? Are we way low? And take it into interpretation with your progesterone and your testosterone and a few other markers that we look at above. Now, that's for a premenstrual female. And I like to talk about that with my postmenopausal females to give them an idea of where their estradiol may have ranged upwards to. But when we're talking to a postmenopausal female, I'm not going to try and shoot your estradiol back up to that ovulatory phase. The purpose of hormone therapy for a postmenopausal female is not fertility. It's not for implantation. It is now for bone health. It is now for cardiovascular protection. It is now for collagen turgor and skin texture. It's now for vaginal health and preventing atrophy. It's now for neurological health and whisking away amyloid plaques. It's now for regulating your lipids and your cholesterol panel. Okay, so my purpose and intent of reference range discussion is to give you an idea of where you used to live in a postmenopausal female, but then to monitor you on estradiol therapy to a certain point, which will be research supported for you to live at for all of the metabolic protective benefits that estradiol gives you without getting you to a fertility optimization reference range standpoint. Okay. So wanted to point that out. That's a little bit of the reference range on estradiol, what we use for menstrual female or menopausal female, premenopausal female, excuse me, versus a postmenopausal. Now, perimenopausal female with estradiol, they're going to be all around town. So some providers won't check it if they know that you're absolutely in perimenopausal. Let's just maybe track your FSH instead. I like to check it just because I'm always science curious, but in theory, in a perimenopausal female, your estradiol is going to be up and down and all around town. It could be 302 on Tuesday and 24 on Monday. And so that's why it's so not needed to check, at least by WorldLink medical standards and would have been trained, because of that variance in up and downness, and what are we really going to do about it? Side note, a perimenopausal female, I generally never put on estradiol. And why not? Well, because it can cause a lot of vaginal bleeding. It can worsen hot flashes. And I've seen some not so fun bloating and foul mood kind of come around. My real belief and what WorldLink Medical stands behind in its teaching is that in the perimenopausal transition, I know I'm deviating away from our lab reference range talk, but I think it's important, you should know, is that in a perimenopausal female, the loss of progesterone is more so the instigating event that's causing the estradiol to be up and down and all around town. Why is that? Because when you stop routinely ovulating, you don't give your body the signal for progesterone to grow in the second half of your cycle, the luteal phase, right? So when you routinely lose your progesterone, you lose control over a molecule that's a mediator between estradiol and progesterone. It's called inhibin. And so if you lose your progesterone, inhibin now has no sensing mechanism, and it's allowed to unpolice estradiol, and then estradiol is allowed to go up and down and all around town. And so that's why you get the variance, 302 on Tuesday and 26 on Wednesday. And that's what causes hot flashes, boys and girls. So we believe in putting back the control mechanism, which is progesterone, to help reset that inhibin enforcement to then balance out that estradiol so you don't get the hot flashing and the night sweats and the mood imbalances and all the things that come with perimenopause and its journey. So just a little caveat sidebar, while we're looking at the estradiol reference ranges, it varies based on whether you are a premenopausal, perimenopausal, or postmenopausal female. We have different target goals and assessments depending on where you are in your journey that we're going to be looking at. And my reference ranges for each of those are going to be manipulated and assessed uniquely depending on your story and your criteria that we're looking at to help you with your health. So that's estradiol and its reference ranges. A little bit of the behind the scenes is what we're doing when you come in to a Kaylin West appointment. If you want to find out more, I'm going to do a few more videos, one on progesterone, another one on testosterone. Just stay tuned.